Prisha,
Yes.
this is Melanie Fox. I'm just going to go to one of the other officers' office where Brandy says she has it up.
Oh, okay.
I'm just going to
Thank
go.
you.
I'll go look at hers. All right. Thank you. Bye.
Well, good morning, everyone. We'll go ahead and get started, and we'll keep entering people as they come into our waiting room. But we are so thankful that you're here today. Thank you for your time this morning to learn about this important issue. Before I introduce our guests, I have just a couple of housekeeping things to share with you. First of all, the session today is being recorded. So if you need to refer back to it, that will be made available for you. And also, if someone in your agency or organization would like to watch this, that will be made available to you as well. We'll have that out by next week. Just please note that viewing the training offline, meaning not live right now today, CEUs will not be provided for that. Following today's training, you will receive an email with a link to evaluation. Please be sure that you do complete that by Monday at close of business day. CEUs will be sent to you directly via email from Family Resource Center. So you want to check all of your email boxes to make sure if you were expecting that email that you did receive that. And those will come out to you within 30 days of today's training. If you have any questions during today's presentation, please put those in the chat box. We'll be monitoring those and then providing those either at the end or throughout the session as it works best. And then also, just as a reminder, please keep your cell phone mute. So with that, I'd like to take the opportunity to introduce Dr. Michael Flaherty, who's been working with us since 2013 on recovery-oriented system of care. And so with that, Dr. Flaherty, I'd like to have you take over for a few moments.
Thank you, Zach. It sounds like there's a little bit of feedback. I hope it's not for everybody, but it's a real privilege and pleasure to be here this morning. And I greet all my friends in Hancock County, Precious, Jennifer, Rosalie, everyone who's there, and look forward to seeing you someday soon when this virus has passed us. It's a real privilege this morning to introduce someone who I consider an esteemed colleague, but also a personal friend, Dr. Rick Rawson. Rick and I have worked together for almost 20 years in various aspects of our careers. He's currently a professor emeritus at UCLA's Department of Psychiatry and also a research professor today at the Vermont Center of Behavioral Health at the University of Vermont, where he lives. He's received a PhD in experimental psychology at the University of Vermont in 1974. Dr. Rawson has conducted numerous clinical trials on the pharmacological and psychosocial behavioral addiction treatments for the treatment of individuals with cocaine and methamphetamine disorders. He was a member of the Federal Methamphetamine Advisory Group to Attorney General Janet Reno up until the year 2000 and represented the U.S. our country at numerous international meetings on methamphetamine. He has led addiction research and training projects for the United Nations, the World Health Organization, and the U.S. State Department, exporting science-based knowledge to many parts of the world. Dr. Rawson has published 3 books, 40 book chapters, and over 250 peer-reviewed articles, and has conducted over 1,000 workshops and trainings, paper presentations, etc. Dr. Rawson and I first met years ago as co-addiction technology transfer leaders funded by SAMHSA, and more importantly to me personally, he was a great asset and help in our work in defining ROSC in its original days in the 2006 period since, where we have both worked along with many of our colleagues to establish ROSC as a science-based service delivery system in this country. So with all of that, I'm really pleased to welcome and introduce to you Dr. Rick Rawson, who's going to speak to us on the rise of methamphetamines, new risks, and current treatment. Dr. Rawson.
There, can you hear me now? I think I'm unmuted. Good morning, thank you, Michael. As Mike said, he and I have known each other going back to, I think it was right around the beginning of the addiction technology transfer centers that SAMHSA set up. and both of us have been involved with the effort of trying to take some of the science-based information that we've accrued over the last 50 years and get it used as the foundation for treatment in the United States. As you all may be, well, some of you may not be aware, but our treatment services in the United States for addiction have kind of been an evolution of community service, self-help, people doing things they thought were helpful, but where science really had relatively little to do with the services provided about the last 20 years. I think the SAMHSA ATTCs have played a big role in that. The recovery-oriented system of care literature has been very important in getting systems built as opposed to individual programs. And so I think the work Mike's done and his colleagues and the work you're doing there is definitely is moving the kind of services that we provide to individuals with substance use forward. And so I hope you're doing well with that work. I'm going to talk about, the title says methamphetamine, but I really should add the proviso that right now, as you'll see in some of the data, cocaine also is increasing. And one of the things that is different about the current stimulant epidemics, or whatever you want to call them, increases, is that the current drugs are very different, much more lethal, much more dangerous. And it's not just methamphetamine. Most of what I'm going to talk about today is relevant to cocaine as well. And although we've had a lot of interest, I get emails and texts almost daily from different parts of the country asking for assistance with helping to do evidence-based methamphetamine treatment. And I often ask, I got one last week from the state director of an eastern state who said, oh, we hear that there's methamphetamine in the southern part of our state, and we really need to develop evidence-based treatment for treating individuals with methamphetamine. And I said, well, that's great. I think that's really a good thing to do. I said, but I'm wondering, you have some big urban centers in your state where cocaine has long been a problem. And if you look at the data, there's about an equal number of people right now dying from cocaine overdose that are dying from methamphetamine overdose. Do you think that you really have good evidence-based treatment for in your inner cities where cocaine is the stimulant that's the biggest problem as opposed to methamphetamine? And there was kind of silence on the phone, and I could tell that methamphetamine now is the boogeyman. Methamphetamine is the current awful thing that's worse than all have ever been. Cocaine and methamphetamine are much more alike than they are different, and their effects on the body and the brain are quite similar. So as you're thinking about service development, methamphetamine increase, also keep in mind that if you're in mostly cities, and it's mostly African-American populations where we're seeing the huge death rate from cocaine, those communities also need to have evidence-based treatment in their treatment centers as well. Okay, as Mike mentioned in my bio, I got my PhD in 1974. I was on a thing for Janet Reno in the 90s. All that seems like an awfully long time ago. And I have to say, when I first started working with individuals with substance use disorders, we were treating heroin users in Ventura County, California. And I think the term addicts was the most professional term we used to talk about our subjects/patients. But we've come a ways. We're now trying to use less stigmatizing terminology. And I will try to do that throughout this lecture using the terms like individuals who use cocaine or methamphetamine rather than addict or drug user. I think I already said drug use. I think I said heroin users. But I'm trying to use the more current term. And I think it's important as we try to reduce the stigma involved with drug use. However, because old habits are difficult to break, and I'm an old dog and it's tough to teach me new tricks, I may inadvertently use the older and more stigmatizing terminology, and I apologize in advance. I will try to use individual. You'll hear me as we go through this. I'll get halfway through a sentence and go back and change my terminology, but I'm learning. Okay, we're going to start. Here's methamphetamine. This is different than the methamphetamine that we were seeing in the US in the 80s when I first started seeing a lot of methamphetamine in Southern California. At that time, it was powder. It was varying shades of tan, red, green, whatever the cookers were using for their formula. It was all kinds of different stuff. But beginning in the late 80s, we started seeing this crystallized form coming in from Hawaii. It was being called ice at the time. And we'd never seen it in this form before, and people were starting to smoke it. And so methamphetamine went the same route that cocaine did. The cocaine transition from powder cocaine to smokable cocaine occurred in the late 80s. With methamphetamine, it was in the early 90s. You started to see this take over as the primary form of methamphetamine. It's now the main way that methamphetamine comes into the country. Now, in the 90s, 80s, 90s, 2000s, we saw methamphetamine being manufactured in the United States. If you watched Breaking Bad, you actually got a pretty good primer on the manufacture of methamphetamine. I actually learned quite a lot of stuff watching Breaking Bad. They did a pretty good job of presenting how methamphetamine was manufactured. This decade or 15 years, the headlines were methamphetamine is the worst thing ever, and these labs blow up and contaminate rivers, and as much of the concern at this time was equal to concern about the effect on the users and effect of the labs themselves on communities and the environment. And this really was, both of those things were big concerns. At that time, the primary precursor chemical, the primary chemical that was used to make methamphetamine was pseudoephedrine, which is in many asthma or many hay fever medicines and over-the-counter medicines. And you could at that time go in and buy cases of it at CVS drugstores and other drugstores. You could literally get, they're packaged often then I think in bottles of 300, and you could buy a big box of those. And that was where the supply came from. And later on they had even bigger, more direct connections to pseudoephedrine suppliers. But pseudoephedrine really was the main drug used in all the home labs that people had in their garages and kitchens, and we lovingly referred to them as Beavis and Butthead labs that were the main supply of methamphetamine during this epidemic. In 2005, Congress passed the Combat Methamphetamine Act, which did a bunch of things to reduce the supply of methamphetamine, probably the most important of which was to limit the availability of pseudoephedrine. If you take pseudoephedrine products for hay fever or allergies or whatever, you'll notice now you go in and you buy it in blister packs. You can get like 10 capsules in a blister pack. You can't go get a bottle of 100. Often, and depending on the state, some states you have to sign your name to get Sudafed products. Others are behind the counter. You have to get them from the pharmacist. And this law really led the way to restricting the availability of pseudoephedrine. And it worked. When we looked at the amount of methamphetamine available in the US, number of users, number of new users, following this act, we saw a dramatic decrease in the supply of methamphetamine and the number of new users. And of course, the labs were pretty much gone. They're not gone, but some meth makers would do something called smurfing, where they'd go around to 10 or 15 or 20 drugstores and buy the maximum number of packets they can, and they can still manufacture methamphetamine, but it really is much more difficult now, and they can only make smaller supplies. So there were conferences that I went to in the 2006, 2007 era where it was, you had a lot of the folks, the supply side people say, there, we've eliminated the meth problem. We've gotten that behind us, and you can really, supply side reduction really does work. And it did work. It worked for about 2 years. The lab explosions have gone away, and that's a good thing. And the availability was down for a while, but almost immediately the drug cartels started moving into the meth manufacturing business in a big way and backfilled the markets that already had been established. And so you did see a drop off. This gives you an idea. This shows you the lab incidents. These are the number of labs seized from 2000 to 2017. You can see it peaked in 2003, almost 25,000 labs. It's down now to about 3,000. So the restrictions on pseudoephedrine really have reduced the lab production of methamphetamine and the number of labs in the US, and that's a good thing. However, as so often happens, as the drug supply moved to a new producer, the cartels in Mexico, they developed a new method of producing methamphetamine using a precursor chemical called P2P, which is phenylpropylene. This is a drug that produces a methamphetamine that is much more potent and much more lethal. And I'll show you some of the data on that. Jane Maxwell, who's an epidemiologist who was at the University of Texas for many years, has tracked this and worked with the DEA on what they see in this drug. And this new P2P method really produces an incredibly powerful form of methamphetamine. And the amount of the US has continued to increase since 2008 and 10 to 2018. It was 10 to 20 times more is being seized at the border. And of course, the border agents generally assume they get 5 to 10% of the drug coming in. So it's there's very few parts of the US right now that are not seeing methamphetamine and don't have methamphetamine available. Interestingly, here in Vermont, we don't see much methamphetamine. It's one of the other states in New England are seeing methamphetamine. I'm not sure what it is that is going on here. There's a lot of cocaine, and I think the drug supply for Vermont comes in from New Bedford, Massachusetts. It comes in through the port there. That typically is a cocaine supply area. So it may just be the peculiarities of the supply system, but most of the country is seeing methamphetamine more or less. It's still more severe on the West Coast and in the Midwest. And in the East and in the urban centers, we're still seeing high rates of cocaine use. Now, as if that wasn't bad enough, starting in about 2014, the methamphetamine and cocaine supply started, the samples that were being seized started to increase rates of fentanyl contamination, that the suppliers were now, as they produced methamphetamine and packaged it and shipped it into the US, were putting fentanyl into the drug before it came into the US. So we saw this phenomenon of what we called speedballing, of mixing cocaine and heroin back in the 80s. And that was a very popular drug combination, but that was done by the user. The user would typically buy some cocaine, buy some heroin, put them together and shoot a speedball. This is different in that this is now put in at the supplier level. And so the user often doesn't know what they're getting. And they don't know it has fentanyl, because fentanyl is extremely potent, and you can't tell by looking at the drug if it has fentanyl in it or not. So in many parts of the country, and I don't know the situation in Ohio, but in a lot of in California, for example, about 60% of methamphetamine samples have fentanyl in them. In some other parts of the country, it's closer to 100% that have fentanyl involved. And here in Vermont, where we see a lot of cocaine, all of it has fentanyl in it. We were giving out test strips to test the cocaine samples to see if they have fentanyl in them, and that pretty much ended because they all have fentanyl in them. So this has been a huge development in that it adds to the lethality of the drug. And as you'll see, this is right now, stimulant drugs with fentanyl are among the leading causes of death from overdose. Most recently in Cleveland, or in Chicago, Illinois, Wisconsin, Iowa, there's been a report of this new drug called isotonitazine, which they refer to as ISO, which is a synthetic form of etonitazine, which is essentially like fentanyl. It's a new version of fentanyl that is now being mixed in with the cocaine. They've seen it mixed in with the cocaine in the Midwest. This isn't a good development. This is, it's sort of the part of the thinking, the DEA thinks that, just to back up a bit, the fentanyl supply that is used by the cartels comes from China. Actually, there was an interruption in the fentanyl supply in January and February because one of the main supply places for fentanyl is Wuhan, China, which is where the COVID epidemic was first detected. And so for a period of months, they weren't shipping any fentanyl out of Wuhan to Mexico. And so the fentanyl was much less detected. However, as always happens, they were able to find another way around that. And one of the ways around it is to come up with an alternative to fentanyl. And it may be that this ISO is one of the things that you'll be seeing more of, unfortunately. But you should know these opioids, fentanyl and ISO are incredibly potent and incredibly dangerous. I'm sure you know that from even from the heroin work. This gives you an overview of the evolution of this last 20 years drug situation in the U.S. Next slide. Oh, I've got to run this. This is the death rate from prescription opioids starting in the late 90s and running through 2017. And as you see, the escalation in the overdose deaths from 1999 to 2010 was a pretty steep, and then they leveled off a little bit, starting in about 2010, and that looks promising, and that's when a lot of states were passing laws and educating doctors about overprescribed opioids, and we started to see some changes in prescribing practices, which were very good. However, at about the same time as there was this leveling off of prescription opioid deaths, we saw this rapid escalation of heroin that more than made up for the little leveling off from the prescription opioids. Then we saw this emergence of fentanyl. These are fentanyl-related deaths that shot up beginning in about 2014, and what is now referred to as the fourth wave of the opioid crisis, increase in stimulant-related deaths, cocaine and methamphetamine, some with and some without fentanyl. And so and for those of you who are old enough to remember back to when we were, working with the stimulant epidemic of the 80s and 90s, we didn't talk an awful lot about overdose deaths. Certainly cocaine and methamphetamine produced terrible addiction and destroyed communities and created serious medical and psychiatric conditions. It would get some deaths, but our concern about drugs producing overdose deaths really started to get really sharpened with the opioid crisis, beginning with the prescription opioid crisis. And I should happen to editorialize, it really got the public's attention when white people started overdosing from prescription opioids, and we started seeing death rates go up in middle-class communities and among kids in our high schools and all of that. That got people's attention. There had been people dying in the other communities for years, but with stimulants, it wasn't really considered a drug where you needed to worry a lot about overdose death. But now clearly it is. And this has caused the life of emergency medical technicians and ambulance people, EMTs, and in emergency departments, a whole new level of confusion in that when they go out to an overdose, it's not always immediately apparent if they're seeing somebody who's had a stimulant overdose, a opioid overdose, or a combination overdose. And then of course you always have alcohol and benzos that get show up occasionally, but it really has, for about 10 years from 2005 to 2015, an overdose generally meant give them some Narcan and they'll come back around. Well, now Narcan works still, obviously, for the fentanyl part of the overdose, but it doesn't for the stimulant part of the overdose. And so EMTs now have a more challenging job on their hands. This gives you a little bit, this is the point I've been making around the not becoming entirely focused on methamphetamine. If you look at the left-hand bars, non-Hispanic whites, you see about these are death on the y-axis is deaths, overdose deaths per capita per 100,000. And you see roughly equivalent numbers of cocaine, the dark blue bar, and methamphetamine, the light blue bar, deaths associated with those two types of stimulants. The middle set of bars, and the third set of bars right in the middle, is non-Hispanic American Indian Alaskan natives. They're the most severely impacted group in terms of methamphetamine related deaths. In the Great Plains, California's tribes and the other tribes Montana has a big issue on the reservations there. Methamphetamine is a huge problem, and the number of deaths are about 4 to 1 methamphetamine to cocaine. However, the second set of bars, if you look at that, non-Hispanic blacks, you're seeing a high rate of deaths, but it's from cocaine, not from methamphetamine. And that's my point is that I started with on this is making sure that as you're building up your capacity to treat people for methamphetamine use disorder, which is a great idea, make sure that the same effort is being given to addressing the cocaine problem, which seems to be most substantial in the African-American communities. This gives you a little bit more detail. This is some data from the CDC. This is cocaine-related deaths 2003 to 2017. The solid blue line in the left-hand panel, take the one with opioids, shows you the rate of increase of deaths where cocaine was involved. And as you can see, starting at about 2014, that line went up dramatically. The two lines below it are the cocaine deaths that include both any opioid, the dotted line, and fentanyl, the dashed line. So you can see that a lot of what's driving that solid blue line is the opioids that are part of the package of this combined drug. You look on the right-hand panel, you see the same cocaine death numbers in the blue line, and the ones without synthetic opioids or any opioids are relatively low. So the message here is that the driver for cocaine deaths really are fentanyl or heroin mixed together with the cocaine, which is, we're still seeing relatively few pure cocaine overdose deaths. However, it's different with ATS, which is short for amphetamine type stimulants, or in this case, methamphetamine. You see the same basic curve. Started a little earlier, around 2012, we started to see the increase in amphetamine related deaths, the solid blue line. But the dotted line and the dashed line, which are those with opioids, are at a much lower rate. They're increasing, but they're at a much lower rate. If you look at the right-hand panel, you can see that deaths without any opioid are at a much higher rate with methamphetamine users. So it's important to realize that people can die of methamphetamine overdose by itself, that the methamphetamine is much more lethal than cocaine on its own. Now, when you add fentanyl in, they're both incredibly lethal, but we have seen these deaths, a lot of deaths from methamphetamine, and the deaths there typically come from stroke, heart attack, or high body temperature running up to 108, 109 degrees, causing death. It's different than with an opioid overdose where it's reduction in your breathing rate. So this is, again, for medical technicians treating people for overdose, this is an important thing they now have to figure out. This study published last year, systematic review of 30 papers on problematic dependence of amphetamine. Amphetamine users have about a 6-fold elevated rate of mortality compared to their non-drug using peers. And men have about twice the rate of death compared to women. And the causes of death, drug poisoning, which are death the way I was referring, where you have this high temperature, stroke, heart attack, accidental injury, suicide, or cardiovascular disease. And I'll talk more about what we know now about the impact of methamphetamine on the heart, because that is where we've seen some of the biggest increases in deaths are related to the heart attack. And just so that I don't forget it, when I ran a treatment center in Southern California called the Matrix Institute, where we treated a lot of individuals who use cocaine and methamphetamine. And we would admit people into treatment, and they would go right into counseling treatment and our whole behavioral thing that we were doing. And generally, we didn't require them to get a physical exam before they entered treatment, because it was we were counselors, we were psychologists, we weren't physicians. And gee, do you really need to add the cost of having a doctor look at these people? They're stimulant users. They don't really need medical care. Well, that was bad practice back 30 years ago. Currently, it's just unacceptable to not have patients be given a physical exam as part of their treatment, because particularly with these current drugs that we're seeing, they produce very serious damage to the body and the brain. And assessing their physical health as a holistic part of providing them with care is really essential. It's no longer okay to not do a physical exam on a patient who is entering treatment for substance use disorder, because the rate at which they have dental problems, they have infections on their arms, they have cardiomyopathy and a variety of other things that really need the entry into treatment really needs to be to treat the whole person and not just focus exclusively on their drug use. For those of you who are involved in providing treatment for people with opioid use disorder, and this has been one of the great positive, I mean, if you think about this whole epidemic thing as being a horrible 20-year experience, one of the few bright spots has been the increased use of buprenorphine, increased use of medication treatment for opioid disorder, more places that people can get treatment in primary care and specialty care and in emergency departments, and that's been a remarkably positive development. One of the unfortunate things about the increase in methamphetamine and cocaine use is that the individuals who are in treatment for opioid use disorder often either already have a stimulant use disorder in addition to their opioid use disorder, or once they get into treatment, that becomes something they start getting involved with. And we were really involved with that back in the 80s and 90s, because at the time we ran a couple of clinics that used methadone as opioid medication. And at one point in the early 90s, well over 70% of our patients on methadone were also using cocaine or methamphetamine. At the time, it was almost all cocaine, but and we saw many patients who had been doing well on methadone for years all of a sudden starting to miss doses, starting to inject again, starting to get involved in crime again, starting to come into the treatment clinic psychotic from their cocaine use. And it really was a huge problem, which never really has gone away. And I'm not sure that we've effectively dealt with it. But now we're seeing very much the same thing with individuals taking buprenorphine who are in buprenorphine treatment. This is data from the state of Washington, where they admitted about 800 people into buprenorphine treatment. About 2/3 of them came in with opioids only as their substance use disorder, and about 1/3 of them were also using methamphetamine at the time of admission. If you look at the retention curves, this is the percentage of people retained over 1,000 days. But and I was impressed to see that if you look at the top line, and the top line is individuals who only had opioid use disorder at admission, they're retained on average about 2.5 years. About 50% of them are retained for 2.5 years, which I thought was pretty impressive. However, if you look at those who came in at the time of admission were also using methamphetamine, that's the lower line, and you see this huge drop off in the first 100 days. Because if you're using methamphetamine while you're taking buprenorphine, you often will be too disorganized to follow through on getting your medication. I think in some cases, those 100-day dropout people were actually kicked out of treatment, because there had been, over time, there's been hopefully a change in prescriber practices, where in the earlier days, if an individual on buprenorphine was using stimulants, the response was to kick them out of treatment. If you warned them, if you sent them to counseling and nothing worked and they continued to use cocaine or methamphetamine, the prescriber would say, well, I can't keep writing a prescription for buprenorphine for you. I think that's changed now in many, if not most parts of the country. And just so that I make sure I say this, don't kick them out of treatment. Find something else you can do, but kicking them out of treatment, with the current drugs on the street being as lethal as they are, when you kick somebody out of treatment, they don't get better, they get worse. And if they're someone who's been on buprenorphine for a week or a month or a couple months, and you kick them out of treatment, they're going to go back to street drugs, and they're going to be at extremely high risk for overdose deaths. So it's no longer that you're kicking them out of treatment and they'll go out there and do whatever they're going to do and they'll come back. They often don't come back because they get dead. So it's finding other alternatives to working with this population who are still using stimulants, but are still in buprenorphine treatment. Overall, their opioid use injection is likely to be substantially reduced, even if they're still using stimulants. But it's a challenging thing. And I mean, I feel a great deal of admiration for the prescribers working with this population. They're not easy to work with. It's not a black and white decision as to what to do about it. And I think there's a much greater appreciation for the whole idea of harm reduction, that we really need to make sure that we do whatever we can to keep these folks alive as our first priority, and then to see them progress in their recoveries. But dead people don't recover. So it's I think it's important to prioritize keeping them in treatment, however you can do that.
Dr. Rawson,
Yes.
we have a clarifying question in the chat room. Matt Rizzo is asking if you are saying that cocaine pushes the body to metabolize the opiate faster.
Yeah, that actually is true. And you would, when you talk with, one of the issues we talked, and when we were doing this in the 80s with individuals on methadone, it was something we collected a lot of data on blood levels of methadone and methadone metabolite. And yeah, if you're using a lot of stimulants, it speeds the metabolism of the medication. In the case of methadone, we would often see people on average, of course, with a dose of methadone, an individual will maintain a pretty stable blood level for 24 hours. If they're using heavy amounts of cocaine, you'll often see that cut in half, where they metabolize methadone within about 12 hours, and then they go into withdrawal, and then they'll often start supplementing with heroin. So you end up with really not only just the addition of the stimulant problem, but a destabilizing of their opioid use treatment progress. So I'm not saying that the stimulant use with these patients isn't important. I'm just saying that kicking them out of treatment isn't the answer. There need to be other answers to addressing that. But that's a good question, and my understanding is that that's correct. The metabolism of the opioid is done more quickly when people are taking stimulants.
And so would any stimulant act this way, is Matt's follow-up question.
Well, I mean, any stimulant, in nicotine and caffeine or stimulants, I don't know that we have a lot of data on those particularly impacting opioid metabolism, but cocaine, methamphetamine, and pharmaceutical stimulants, drugs like Ritalin, if used at high levels. Now we're talking about, again, you're talking about someone taking these powerful psychostimulants at very high levels, which interfere with the metabolism of the opioid. If someone is under a doctor's care, taking Adderall for ADHD, and they're following the prescription and taking it at the prescribed level, I'm not sure there's a lot of effect on opioid metabolism when taken on a constant blood level, relatively low, as compared to taking a big blast of crack and or smoking ice and getting a huge effect. So in principle, yes, we're talking about the powerful psychostimulants, cocaine, methamphetamine, and pharmaceutical stimulants of that type. Yeah. Okay. Okay, so let's talk a little about impacts of methamphetamine use. Martin Paulus, one of my colleagues from UC San Diego, just recently published a great new review paper in JAMA Psychiatry earlier this year. And I think he did a great job, although I disagree with his section on treatment, and I'll talk about that. But he does a good job of reviewing the neurotoxicity and cognitive effects and the other medical issues. First off, as you heard earlier, my work with methamphetamine started in the 80s and 90s, and particularly in the 90s when we were seeing individuals with meth use coming in to treatment, we started collecting data. One of the ways the matrix model got discovered and began being used was that in the 90s there was virtually no data at all on what worked for treating people with methamphetamine use disorder. And we happen to have data from our clinical work we were doing in California, and that provided the interest and the matrix treatment stuff developed out of that. But the other thing that was going on at that time in the 90s was we saw for the first time research using techniques like and MRIs and other brain imaging techniques. And since the big bunch of people we were seeing were methamphetamine users, we started to get a lot of data, Martin Paulus being one of the folks, Edie London, my colleague, UCLA, Nora Volkov, all of those brain imagers really started doing a lot of their work around methamphetamine effects. And it was a fruitful area of work because methamphetamine produces profound brain changes. The dopamine system is what we know the most about, that methamphetamine affects the dopamine system, damages brain cells, kills brain cells, and affects all kinds of neurological functioning. And to where we now really think in your providing treatment for this population, that these are people who have traumatic brain injury, not like traumatic brain injury, actual traumatic brain injury. Their brain has been altered by the effects of methamphetamine, And according to Martin, the overall altered brain state is consistent with degenerative central nervous system diseases, things like Parkinson's that people have. So when you're seeing this population, you know, it's not, these aren't just people with a bad habit who are doing these bad drug using things. They actually have damaged their brain and their ability to participate in treatment, their ability to follow and comply with recommendations, and to follow through with any kind of plan of action often is impaired. Cognition is one of the areas where we have the most data. There's been a lot of information on the cognitive impacts of methamphetamine. And after people stop using methamphetamine, you still see damaged effects. It's not as though, you know, the day after they stop, their brain goes back to normal. You see poor performance on motor and processing tasks, poor performance on verbal fluency. The whole verbal issue with individuals who have used methamphetamine is pretty profound. They really have a great, like me right now, a difficulty finding words. They're not as verbally literate as under non-drug using situations. And even after prolonged abstinence, you see, you also see poor learning efficiency and comprehension, visual spatial processing, and other deficits. In general, over time, these cognitive effects improve and for the most part are reversible, but you do certainly see with some of the long-term injectors who have been heavy users that some stuff never comes back. We saw that when I started in 1974, as I said, at that time we had these less than professional terms. The speed users at the time often were referred to as burned out speed freaks, which were people who had taken too much methamphetamine, injected too much amphetamine and methamphetamine over time, and their cognitive ability never came back. And people have what was clearly serious cognitive, prolonged cognitive effects. It's not quite severe with most of the patients we see, and most of it's reversible, but it's clearly there. And when you're working and providing treatment with this population, it's important because they do experience cognitive damage. Estimated about 2/3 of those with methamphetamine disorder have cognitive impairment. The impairments associated with older age, longer duration of use. I missed one here. It should say route of administration, with injectors being much more severe cognitive damage and greater frequency of use. So if you're older, if you've used a long time, if you've injected a long time, if you're using every day, you're going to have more cognitive impairment than others. And of course, this has implications on treatment, particularly when our treatments are talk therapies and things where we're sharing information back and forth with the individual in treatment. A lot of it just never processes. And so it means we have to do a lot of repetition. We have to do a lot of making sure, you know, keep it simple. Keep it simple is a, you know, common term we hear, you know, in self-help meetings. It's also a brilliant piece of cognitive behavioral therapy, as is one day at a time, to help people simplify and focus their recovery activities because they have trouble focusing. So using very simple things, repetition, all that are important. Methamphetamine and violence, there's been a review of 28 studies. The issue here is that individuals who use methamphetamine become psychotic. Almost all of them at some point during their meth use will become psychotic. Some of them, it becomes more progressive and they will only need to take a little bit of methamphetamine and they'll become floridly psychotic. This was something we dealt with in the 80s and 90s in the emergency departments in California, where if they would see somebody being brought in with a psychosis, they just assumed they were a meth psychosis. Sometimes they were people with schizophrenia, and it was very hard to differentially diagnose them, but the The psychosis is a very common effect of methamphetamine. It's clear that it's not just the amphetamine, it's generally a combination of the amphetamine effect with sleep deprivation, because a lot of times people will go 2, 3, 4 days without any sleep, and their psychosis often blossoms when they're at the later stages of those long runs of chronic amphetamine use. And the violence issue occurs when they're psychotic. Rarely do individuals who use meth, become violent unless they're psychotic. And so when you're working with this population, it's very important to have protocols in the treatment clinic for what to do if a patient becomes agitated, or how to make sure that they're not provoked into violence, because it can be, the clinics I ran over the years, I'd run clinics for individuals with opioid use disorder for 15 years, going into the late 80s. And I don't think we ever had to call the police or the emergency technicians. Once we started seeing amphetamine users come in, it wasn't a common occurrence, but we did have to do it from time to time, because people would be psychotic, and we needed to get some help for the staff. So it is a challenge. I mentioned that there is data on cardiovascular disease. It is the leading cause of death with meth use disorder. We see strokes. The data have been mostly on young men, but so you're seeing 30 and 40-year-old individuals dying of stroke. And that's in the regular world, that's pretty unusual. I mean, very unusual, very rare to see individuals with stroke. But now with methamphetamine, you see that. You also see cardiovascular issues like hypertension, arrhythmias, and cardiomyopathy. So it's, this again is, my point is that when you're treating the individuals in this population, they really do need a physical exam as part of their treatment process, because they are at risk for brain injury as well as heart attack and other issues. They also are the injectors, of course, are very high risk for hepatitis C. We see a lot of hepatitis C among the injectors in this population, as well as infections, endocarditis, all of those kinds of infection-related disorders. This is a review of the stroke. Actually, it should be 77 articles. And it just shows that the types of strokes that occur, generally the hemorrhagic strokes, which are the blood vessel in the brain ruptures, that kind of a stroke, that tends to occur with injection use. Where the blood vessel constricts, stopping the blood flow, those ischemic strokes, those typically occur with smoking methamphetamine. Either way, you can die from these either way, as you can see. A third of the hemorrhagic strokes died, and a fifth of the ischemic stroke individuals died. These are some of the signs. If you've not ever been aware of what a stroke looks like, or what an individual with a stroke looks like, these are some of the symptoms: numbness, headache, speech and language difficulty, vision problems, and dizziness. And if you see individuals coming into your treatment services with these symptoms, even if they're in their 30s or 20s, this should be considered, because it is something we're seeing a lot more of now than before. Pregnancy. This is a review published last year, a meta-analysis of stimulant use in pregnancy. In general, and I don't remember exactly where this specific statistic came from, but the women are disproportionately, some of the studies I did, where you see higher rates of stimulant methamphetamine use among women than other drug use disorders. That's been something we've seen since the 80s. And you do see a pretty high proportion of drug using in women who now use drugs. Methamphetamine is the drug of choice that you're often seeing. and the women progress from their initial experimentation with the drug, the stimulant, to addiction much more quickly than men do. And I'm not sure I understand the reason for that, but their use will become more severe more quickly. This is a meta-analysis of 31 studies on cocaine use during pregnancy, and it's been well documented. I don't know if any of you were there during the early cocaine epidemic, where we had this hysteria about cocaine exposed babies or fetuses, prenatal exposure of cocaine use, producing these people who would have, you know, we're going to be criminals and we're going to have terrible things happen to them. And it was clear that that whole hysteria was exactly that, hysteria. It was on Time magazine had a story on it. It was just like, using cocaine when you're pregnant one time will cause these mutants that will be your babies. Well, all that stuff was, you know, not based on any kind of science. However, more thoughtful studies, more careful studies have documented that cocaine use during pregnancy does increase the risk of preterm delivery, does result in lower birth weight, small for gestational age, earlier gestational age at delivery, and reduced birth weight. With methamphetamine, the 8 studies have documented that pregnancy use during pregnancy, earlier gestational age at delivery, lower birth weight, and smaller head circumference. Individuals, the babies who are born with mother using methamphetamine have a more severe withdrawal, that is drowsiness, respiratory depression, and jitteriness. And I mean, you get some of those symptoms with babies born to mothers using cocaine, but they're more severe. The big difference between, well, there's a couple of big differences between cocaine and methamphetamine, but one of the big differences is the half-life. Cocaine is about an hour or two. Methamphetamine is 8 to 12 hours. So it produces a much longer effect. And you see generally more severe effects with methamphetamine than with cocaine. Cocaine and methamphetamine are excreted in the breast milk. And so if the woman after delivering the baby is continuing to use stimulants, breastfeeding is contraindicated. There's been a number of studies on what happens to these children who were prenatally exposed to methamphetamine. Chris DeRoth at the University of Hawaii led a big NIDA study on this. After delivery, a month after delivery, about a third of the women who were methamphetamine users had lost custody of their children. So about a third of them, kids were taken into other living situations. At 3 years, the children prenatally exposed to heavy meth use, that is 3 days a week or more, you saw higher rates of anxiety, depression, and more attention problems among the 3-year-olds. Among those at 7.5 years old, methamphetamine exposed children had poorer cognitive functioning. We actually did a similar study, and we looked at 5-year-olds, 4 and 5-year-olds exposed. Their mothers were using meth during their pregnancy. We had about 50 kids we did testing with. What we found compared to non-exposed controls was a much higher rate of verbal learning deficits. They had a much more impoverished language capacity, the ability to speak, to have their number of words they used was much lower. Their ability to read was much more impaired. So we saw the effects particularly on language related issues. And so the kids who are exposed to methamphetamine prenatally do have some protracted effects. Nora Volkov published an article earlier this year on the impact of COVID on our work with people with addiction. There's all sorts of stuff coming out right now. There's articles every day on the impact of COVID. Nora's article really talked about a couple of things. One, that individuals who use drugs, particularly if they smoke or vape them or use opioids, all things which affect the lungs and suppress oxygen turnover. All of those things, if a person who does those things gets infected with COVID, they're much more likely to have a severe COVID response. That is, because of their lungs have been impaired. And so you do see a higher fatality rate. As you can see, the people with any kind of disease have about a 3 times higher rate of death than those without respiratory problems. And our population generally, in many ways, could be defined as having a respiratory abnormality. Secondly, we're seeing much higher overdose death rates. This year, they're up, depending on where you look in the United States, they're up anywhere from 20 to 40% over the rates last year. And so the pandemic really has exacerbated our efforts with addressing addiction by causing, really spiking the whole overdose death issue. And as people have isolated, I mean, it's thought that that's because people are more isolated. If they have an overdose, they don't have a friend there with naloxone to bring them around. And that's one of the factors. Also, that the whole isolation, stress, anxiety, concern just generally leads to more drug use and consequently more overdoses. I'm sure you're going to see a lot of information on this in much more detail, but this is just one quick overview of that issue. And I'm at 1 hour and we've got 2 hours. If anybody wants to take a break for a couple of minutes, we can do that. I'll get myself a little more coffee and give you about a minute and we'll go on to the clinical issues. Listening to me talk straight for 2 hours is just not, it seems like it's unconscionable, but so I'll take a quick break.
Thank you, Dr. Rawson.
Okay, if If anybody, whoever is looking at the questions, if you have any, if you want to do any of the questions right now, we could. If you think there's any that we should address before we go on to the next part.
Dr. Rawson, there was conversation in the chat room about why people would lace meth and cocaine with fentanyl, and what was the motivation for that?
That's a good question. And when we first started seeing it, I mean, we had seen it in the heroin for a couple of years before it started to be showing up in the stimulants. It's like, well, why would you do that? It's because it produces a very powerful, positive experience for most people, not all, but there are individuals who use methamphetamine and cocaine who don't like having fentanyl in it. But most of them, particularly the meth users, individuals who use meth, will say things like, well, when you inject meth, you get this huge dopamine, well, they don't say dopamine surge, they'll talk about it being high, this incredible high that occurs, and it takes your breath away and it produces all that effect, and you get up there and then gradually you come down, and the coming down part isn't very pleasant. It often is kind of, they refer to it as tweaky, and they get kind of anxious and a little paranoid. Well, the opioid part, the fentanyl part, smooths that out, and they talk about it being a much more the entire experience being positive, not just the escalation of the initial drug, that they really like the warm opioid hug they get from the fentanyl. And also it also for many people increases the that initial euphoria at the same time. I mean, we saw it with speedballing. I mean, people who would take cocaine and mix it together with heroin and speedball, that would very rapidly become their drug of choice. That combination is a good combination. And the drug traffickers, again, these are, when you think about the current drug trafficking groups that are involved, these are not mom and pop operations. These are highly organized and very sophisticated drug experts that they knew what they were doing. And there's also the thought that that stimulant dependence issue is a terrible one, but if you get them moved toward opioids, you much more likely have a long-term customer because you really can't stop the opioids. You can stop the stimulants, but not the opioids. So from a trafficking point of view, they're attempting to sort of sustain their customer base for a longer period of time.
Thank you. Matt Rizzo, you might want to unmute. And I apologize, early on you asked this question. We were dealing with getting people into Zoom. So you asked what % had fentanyl in it. I'm assuming Dr. Rawson was talking about the amount of stimulants that had fentanyl in it. But if you want to further clarify that question, Matt, please do.
No, that's exactly it, Jennifer. I was wondering when they looked at the meth use, if you will, and maybe they kind of broke it down by substance. What percentage was fentanyl? What percentage was meth? What percentage was cocaine? I just kind of wondered, what that breakout was. So, and I think just kind of while I'm unmuted, the other question I have was, there was discussion about, using cocaine or a methamphetamine that would really kind of metabolize the methadone quicker. Somebody had asked, did it act the same way with buprenorphine? So those are the two questions.
The second question on buprenorphine, I don't know the answer to that. The pharmacologist who, my colleague Walter Ling, who is one of the world experts on buprenorphine, in his talking about how buprenorphine interacts with the receptor, it's different than how methadone interacts with the receptor. So I'm not sure exactly that it's the same phenomenon. And so I think my best answer to that one is I don't know. although I would suspect it does. I would be, that would be my hunch. As far as the issue of the what's more of or less of, first off, there's the question of, in any given area, if you go out or if the DEA seizes 20 different samples of methamphetamine, what proportion of them have any fentanyl in them? That's one question. In California right now, across the state, it's around 50 to 60%. If you go down to San Diego, it's 100%. In Vermont, the cocaine, 100% of the cocaine samples have fentanyl in them. So that's one issue. The issue of, in any given sample, how much of it is meth and how much of it is fentanyl, I'm not sure how to answer that. There's methamphetamine, generally, you only need a tiny amount of fentanyl to kill people. And so in any sample, there's not very much fentanyl because you don't need very much fentanyl. And in fact, one of the big challenges and one of the big overdose issues is the user doesn't know how much fentanyl they're getting. And so, you know, they often say things like, well, my dealer, I've bought from this guy for, 5 years. He would never sell me, too strong or dangerous drugs. They don't know what they're getting either. I mean, the cartels don't label that this is 2% fentanyl or 1%. We don't know. And the user, it's truly a Russian roulette issue. I mean, in general, in terms of the actual amount of the substance, the amount of, if you've got the crystal powder, I would expect most of that is methamphetamine or cocaine, and only a tiny amount is fentanyl, but you only need a tiny amount. I mean, and we haven't even talked about the issue that I think you folks in Ohio, I think it's Southern Ohio, had a year or two ago where carfentanil showed up. Carfentanil is 100 times more potent than fentanyl. And hopefully that's not going to be showing up much more. The DEA says in their discussions, whatever they do with drug traffickers, the drug traffickers realize that carfentanil is too potent that they'll kill all their customers. So they're not likely to be using carfentanil, but who knows? I mean, these traffickers are not exactly, medical, they're not the FDA, but.
We have
Okay,
two more, Dr. Rawson, we have two
Yep.
more questions, if
Okay.
you don't mind. One is, can you talk about Vivitrol patients that are turning to meth? And then the last question is, what role you see harm reduction programs such as syringe service programs, and safer education playing in this continuum of services?
On Vivitrol, as we have seen with methadone and buprenorphine, if you provide a medication treatment for opioid use disorder or alcohol use disorder, these are to people who have the disease of addiction, and they're at high vulnerability to develop other forms of addiction and stimulants. If stimulants are available, they're quite at risk to develop stimulant use disorder, whether they're on buprenorphine, methadone, or Vivitrol. Now, there is one issue that naltrexone, the active ingredient in Vivitrol, has been one of the medicines they're looking at for the treatment of stimulant use disorders. And so we don't know the whole story there yet, that naltrexone may have some benefits to reducing stimulant use, but I can tell you from personal experience with when I was doing naltrexone research, stimulant use by that population was substantial. It isn't as if you inoculate people by giving them Vivitrol or naltrexone. So we don't know. I would say if they're on Vivitrol, they're equally likely to develop stimulant use disorder as people on other medications. Harm reduction, I'm going to talk about a bit. I think harm reduction is a tremendously important part of our addressing the stimulant use issue, methamphetamine and cocaine, because as you'll see, individuals using methamphetamine and cocaine are not especially interested in treatment. But our ability to help with syringes, with help medical services with other kinds of services that maybe aren't helping them get drug free, but are helping them stay alive and helping them minimize the medical and psychiatric impact of their drug use is, I think, essential, because these folks are not chomping at the bit to get into treatment and enjoy the bounty of recovery. Many of them for a long time don't think they're addicted. And so I think with stimulant use disorder, harm reduction services are of critical importance and need to be far more widely applied than we're currently doing. So let me go on to the next section, clinical challenges. As we've already talked about, overdose death is a big challenge, and don't kick people out of treatment because they're likely to die of overdose. Mentioned, just was saying, limited understanding of stimulant addiction. Individuals who use cocaine and methamphetamine look at their colleagues using opioids, and they see that the individual using heroin or fentanyl or prescription opioids, they need to use every day, generally several times a day. And if they don't have their drug, they get anxious, and if they are worried about going into withdrawal, that becomes their obsession, and they're all freaked out about that they don't have their next dose. Stimulant use disorder, not so much. Stimulant use disorder, people will stop and start and go in binges and will go for a week without using, or going 3 or 4. And so they look at their own use and they say, well, look, I can stop for a week. I'm not like him or her who's an has opioid use disorder. So I don't think I'm addicted. I think I'm just using when I want to use. If you don't think you're addicted, if you don't think you have a problem, your level of ambivalence about stopping or reducing your use is considerable. So you have this issue with individuals with meth and cocaine use disorder who generally are less convinced that by their disease that they need to get into treatment or they need to do anything to change their behavior. Because of the effects on the brain, they have impulsivity and poor judgment, cognitive impairment we talked about. One of the hallmarks of stimulant use disorder is anhedonia. For any of you who are familiar with the matrix model, in there we described that, we called it the wall, which is this, and we actually observed this clinically before it's been documented with science, that individuals in the early months of stimulant recovery have this anhedonia. Nothing feels good. Nothing, it's like life sucks. And you hear them say things like, if this is the way it's going to feel to be sober, I don't want to live this way. I can't live like this, which can often be part of the relapse dynamic. We now know what this anhedonia is. It's the dysregulation of the dopamine system that takes months to recover. You can actually map it out over time, and you see something that lays right over what this period is we call the wall, which lasts out to 4 to 6 months, is in brain imaging studies is clear that that's how long it takes for the most recovery of the dopamine functioning. And so this is normal. It's a natural part of the early recovery process for people to not be very enthusiastic and to say things like, there's nothing I can do to feel good. I just don't feel good. They're not depressed. I mean, they may also have depression, but this is a unique, well, it's a commonly experienced part of early stimulant recovery. Hypersexuality, stimulants, methamphetamine, well, both meth and cocaine become very much tangled up with sexual behavior, often involving with methamphetamine, long binges of sexual behavior, more extreme sexual behavior, lots of that stuff. In recovery, it often can be hyposexuality or loss of sexual drive, which can freak out people that they're never going to be able to have sex again. And so I got to use meth to be able to function. So as I tell counselors when I do training, if you're going to treat individuals with stimulant use disorder, you better get comfortable talking about their sexual behavior, because it's a big part of their recovery, and and try not to blush or try not to gasp when they talk about what happened with their sexual behavior during their use, because it often tends to be pretty extreme, much more so than with opioids. With opioids generally replace sexual behavior. With stimulant use disorder, it's a much bigger piece of their treatment issues. I mentioned violence and psychosis. This trigger craving response, going back to the comparison with opioid use disorder, with individuals with opioid use disorder, sort of the hub of their addiction at the time they're entering treatment is around avoiding withdrawal. Withdrawal is the big thing. They don't want to get into withdrawal. They're afraid of withdrawal. They need to get money to get with all of that becomes the sort of the hub of their, and when they are offered buprenorphine or methadone as a way of reducing that, it's often a very attractive part of the treatment alternative. With stimulant use disorder, that's not the dynamic. The dynamic is this Pavlovian craving that they experience. They can be doing just fine and go out, somebody gives them a $50 bill to pay an old debt, and all of a sudden their brain lights up and all they can think about is using. And someone who's doing well in recovery, if they hit one of these triggers, it's as if they have no control and they're often using. And so it's a bit of a different dynamic than with opioid use disorder. Obviously, many of them have psychiatric comorbidity, and our biggest challenge with this population is retaining them in treatment. They're ambivalent about going into treatment, and then they get into treatment, and then they have this anhedonia, and nothing feels good. You get high dropout rates. These are some of the groups that require special consideration for the treatment issues, people who inject and people who use daily. For those two groups, and sometimes they're doing both, are going to have a higher, they're going to need a higher level of care in the early part of treatment. It's very hard for people using daily heavy amounts of meth or injecting meth to immediately go into outpatient treatment. They're too unstable. Their brain just isn't working well enough to allow them to stop using. Women, you see, as I mentioned, you see higher rates of women with meth use disorder than with other substance use disorders. And many of them come into treatment. Generally, all the data we've collected, they have higher rates of depression when they come in. They have report higher rates of physical and sexual abuse. So trauma-related therapies are an important part of providing treatment for that population. The homeless, chronically mentally ill, people with high psychiatric symptoms, clearly they need additional services compared to others. Men who have sex with men in the methamphetamine literature has been for 30 years a high priority population. They have higher rates of meth use among MSM, which is interestingly not just a US phenomenon, it's all over the world. MSM are a higher use population with methamphetamine, in part because methamphetamine and their sexual behavior gets all connected up, and when they experience sexual arousal, it sort of is like meth craving and vice versa. But it also is associated with high risk sexual behavior, unprotected sex, and this population is a very high risk for HIV transmission. So it's been a real high priority population. Younger meth users require some additional consideration, and certainly those in medication treatment for opioid use disorder. We need to get treatment into that population to make sure that all these gains we've made from getting buprenorphine more widely used, we don't see, you know, a reduction in the effectiveness of that treatment because they're using stimulants. Okay, here's some clinical interventions. I thought this was an interesting one published late last year on starting to look at overdose treatment with individuals with severe meth overdose. This was a couple of cases. I think these one was, this one's in Indiana, and this one, I don't remember where the second one, but case one, a 21-year-old unresponsive after ingesting methamphetamine, body temperature 107.9. They used the standard cooling methods that are used by EMTs, blankets and bags of ice, and they found that it didn't bring down the temperature that much. After 46 minutes, the temperature was still 104 degrees. They then took a body bag, which they generally use for bodies, and filled it with an ice slurry and put the person in that body bag with ice and brought their temperature down very rapidly. This second case, that's the technique they used right away. This one was found 46-year-old, 107 degrees. They were immediately put into the body bag with the ice slurry, and the temperature dropped to 98 degrees in 32 minutes. So this is now a technique that maybe you may see and used more commonly. This is the time course. The first case is the extended time course out to whatever number of minutes that is. And the second case, the temperature drops more quickly. So this putting them in a body bag and, you know, immersing them in ice definitely reduces the body temperature and may save their life more quickly than other methods of bringing down their temperature. I mentioned harm reduction strategies. This is not an adequate slide because it's a slide I did probably 6 months ago, and I've since been talking to some of the harm reduction places that are doing some other things, but here's some things that are certainly important: educating patients on the effects of this drug, making sure they know about fentanyl and the danger of fentanyl, providing them with clean syringes. Given that there's so much fentanyl in the methamphetamine and cocaine, it may be worth considering providing them with naloxone to take home to, in case whatever the overdose is includes fentanyl. And then there's some generally supportive activities. There's a group a couple of groups that are now giving out pipes, and the message to users is, if you're going to use, don't inject, take it this way. Obviously, that isn't there's not universal acceptance of giving out pipes to meth users, but there is a whole other array of new things being tried that I need to update my slide with. But again, as I'm going to show you right, yeah, here's this. This is data just published from a syringe exchange program in Washington State, where they did about 2/3 of the individuals that they were interviewing here were individuals with opioid use disorder. 1/3 were individuals using meth. They did a whole battery of questions with them. 82% of the individuals who used opioids said that they recognized they needed to reduce their use. They planned to reduce their use or stop their use. They planned to get into treatment. With the individuals who used methamphetamine, it was less than half of them that saw the need to do that. The point here is that this is a population, these stimulant using individuals who many of them are not at the, in the stages of change things, you could call them pre-contemplators, whatever, but they're not at the point where you're going to be able to get them into specialty care, to be abstinent, and to move into recovery. So having other services that can help reduce their death rate and reduce the damage done to them by their meth use certainly becomes much more of a priority. And that's been a relatively poorly developed area. And I think we've got to do a lot more work there. We have a project that we're just starting in California with primary care doctors on finding out exactly how people with methamphetamine use present in primary care. What are the things that they present with? Psychosis, infected needle marks, heart problems, high blood pressure. And what can we do to address their medical issues if they are or aren't interested in getting into recovery? So that has been a very poorly developed area. So we're working on that right now. treatment for stimulant use disorder. This is probably what some of you are interested in. And it's a very quick, oh, here's one set. I will go through these quickly and you can get these slides. The clinical management of individuals with psychosis, there's not a very clear protocol. Generally, people have auditory hallucinations are the most common, visual hallucinations also. Generally, it's transient. If you can put them in a quiet place and keep them from hurting themselves or others for, 3 or 4 hours in a room that's quiet and let them just sort of come down, that often is the most expeditious way of dealing with them. Sometimes risperidone is necessary to help reduce the severity of their psychosis, or benzos can be helpful in a very short term. You have to monitor them with hyperthermia and dehydration. Intoxication, pretty much a similar picture. People who come in extremely agitated and excitable possibly may need short-term benzo application, talking them down, not confronting them, getting them out of a loud environment into a quiet environment. And generally, as the drug metabolizes, they will come back down. But sometimes they can be so agitated that medication may be necessary just to keep them from hurting themselves. There's not a good withdrawal protocol for, generally it's letting them sleep and eat and get back to normal. They may need short-term medication to help them sleep if they're so amped up that they can't sleep, and that's part of their withdrawal syndrome. But there's not anything like methadone or buprenorphine with opioids that help them reduce their symptoms. So the withdrawal protocol is relatively rudimentary. This just says we've done a bunch of studies with individuals with meth use disorder and cocaine use disorder in the same studies, using the same treatments with the same staff at the same time, and the results we get from behavioral treatments are virtually identical. So it's not like you need one set of treatment for cocaine users and another set of treatment for individuals who use methamphetamine. The behavioral treatment literature would suggest they respond equivalently to behavioral treatments. Very quickly, since it's a very easy topic to cover, medications for meth use disorder. Bupropion and mirtazapine are the two leading candidates. Wellbutrin, which is bupropion, Remeron, which is mirtazapine, both have multiple trials, double-blind trials showing positive benefits. There have been some studies with naltrexone, with Ritalin, with amphetamine itself, and topiramate, mixed reviews, some positive, some negative. But the two, bupropion and mirtazapine, I think NIDA has got both of these in trials again right now. And I think they're very promising. However, when you talk to the clinicians who use these two, it's not like giving an individual with opioid use disorder a dose of buprenorphine or a dose of methadone. They don't feel better. They don't go, oh, now I don't have craving. They go, well, I don't feel quite as wiped out or low energy, and my craving's not quite as bad. So I don't think right now we have any agents that are going to play the same role that buprenorphine has played in the addressing opioid use. We need one. This is important. There's some vaccines currently being looked at, but I've been involved in this. The first publication I did on methamphetamine was in 1981, where I did a study with the doctor I was working with on the use of imipramine, which is a tricyclic antidepressant, and it didn't work. And I then made a career of about 30 years of publishing studies on medicines that didn't work for treating individuals with meth use disorder. I'm saying that facetiously. I was an investigator on one of the bupropion trials, but it's been a very frustrating thing. Early on in the 80s, we would have people saying, oh, we found the medicine that works. And then you'd put it into double-blind trials and it would go away. The effect would go away. Sort of reminiscent of hydroxychloroquine for the treatment of COVID. Double-blind trials are important parts of establishing a medication's effectiveness. So we're still working on this. Behavioral treatments. I've got a bunch of them here, and these are all meta-analyses or systematic reviews of treatments for individuals with stimulant use disorder, cocaine and amphetamine. This first one was published in 2018 by a group from Oxford University in England. They're not an addiction group. They're a meta-analysis group. They know how to take big bunches of literature, sift through it, and now get a formula for the conclusions, and they're able to say whether or not things work or not. I just want to double check. I just got a signal that my signal is unstable. And people still hearing me?
You're okay now. You were just for a short period.
Okay, great. I'm on. I mean, I have a hard wired, so it's not my internet, but I did get that signal. Okay, very quickly. This was an analysis of 50 studies with 7,000 patients, 12 different interventions, and the conclusion of the meta-analysis was the combination of contingency management and community reinforcement approach was the most efficacious and most acceptable treatment in both the short and the long term. Now, this is unusual in my experience. Meta-analyses usually say things like, well, the evidence wasn't very good and we really couldn't give you a definitive answer. In this case, they gave a very definitive answer: contingency management and community reinforcement approach. This is a group that did something called the Cochrane collaboration, where they do meta-analysis of literature. They looked at 27 studies and found that their conclusion was the comparison between different types of behavioral interventions showed results in favor of treatments with some form of contingency management, both in response to reducing dropouts and lowering cocaine use. So there's a second meta-analysis, contingency management coming up as one of the most robust treatments. This is a recent study by the Australians, published in the prestigious journal The Lancet, on challenges of treatment stimulant use. Psychosocial interventions other than contingency management have weak and non-specific effects on stimulant problems, and there are no effective pharmacotherapies. So a third systematic analysis pointing to contingency management, here only contingency management, as having robust effect. This is a study published here in the US about 2 months ago, 44 studies reviewed. While contingency management interventions showed the strongest evidence favoring outcome, there was some evidence for CBT alone and CBT with contingency management. So again, another vote for contingency management. And then, by the way, there are 2 others that I haven't listed on here. So it's a really remarkable consistency among these big analyses saying that contingency management is has the best evidence. And this was just published last week by these investigators. They reviewed 27 studies in which contingency management was used for the treatment of methamphetamine use disorder. All of them had contingency management for individuals who used methamphetamine. They looked at drug abstinence, retention and treatment, attendance, sexual risk behavior, mood affect, and treatment response predictors. 27 studies, methamphetamine was reduced by contingency management significantly. Longer retention in treatment from contingency management, more therapy sessions attended, higher use of other services, reduction in risky sexual behavior, and increase in positive affect and decrease in negative affect. These contingency management results were remarkably consistent. People who did best in contingency management, HIV negative, this is the statistical sorting out of what associated with good treatment response. HIV negative people did better, fewer years of lifetime drug use, less meth use at baseline, Caucasian, lower monthly income, more years of education. Those who spent If they were in contingency management and they earned vouchers that they could trade in for something, those who spent their vouchers and got the reward immediately did better. And those who injected did not do so well. So right now, the status is contingency management has by far the best evidence. There is some evidence for CBT, some evidence for a community reinforcement approach. Motivational interviewing doesn't have much in the area of methamphetamine, but does in the area of cocaine. There's some evidence for MI. And we published a big study with multiple papers coming out of it on physical exercise, having very robust treatment effects, but it's only one study, so it doesn't yet, match up with that. I just want to say a little bit about, for some of you who don't know what contingency management is, it's also called motivational incentives, and I'll quickly go through this. A technique that employs the systematic delivery of positive reinforcement for desired behaviors. In the treatment of methamphetamine dependence, vouchers or prizes or gift cards are earned for positive behaviors, like giving methamphetamine-free drug samples or attending treatment sessions or showing retention in treatment. So what you're doing is providing reinforcement, reward, incentives to people for positive recovery behaviors. And I won't go through all this because I'm running short on time, and I don't really have time to do a CM training, but contingency management, the data are really overwhelming, as I just reviewed. It's shown that if you give incentives to individuals in treatment contingent upon their target behavior, if you're going to do drug-free urine samples or meth-free urine samples, you provide a reward immediately after you get a drug-free sample, you'll get more drug-free samples. If you provide a reward for people showing up for treatment, more people will show up for more sessions. Very simple. We use rewards in all kinds of aspects of our lives, and they work. Nancy Petrie, the late Nancy Petrie, who passed away several years ago, developed a method called the fishbowl, which allows for variable reinforcement. And if you want, I'd be happy to talk at some future time about some of the specifics of contingency management. John Roll led a clinical trials network study on use of contingency management for methamphetamine dependence. Everybody got behavioral treatment. Actually, it was the matrix model with a multi-component behavioral model. Half of them also got contingency management where they earned incentives for drug-free urines. The other half did not get that. This shows the difference in retention and percentage of negative samples. Those who received the incentive stayed in treatment longer and gave far more drug-free samples than those who were in just the behavioral treatment itself. We've published a bunch of studies, and again, I want to leave time for discussion. This is one we ran where we were treating individuals in treatment with methadone. They were opioid using individuals. They also were using cocaine. And the methadone was doing a job generally of reducing their opioid use, but they were often daily using cocaine. We randomly assigned them into 4 groups. One group just got standard treatment, just standard methadone treatment. One group got contingency management where they earned vouchers to reduce their drug use, but give positive or give negative drug samples. One group got CBT, and then one group got both CBT and contingency management. This is the urinalysis data. The methadone maintenance only group gave 11 drug-free samples out of a total of 48 possible in the 16 weeks. The CBT group gave about 20 negative samples. The 2 groups that got contingency management gave about 50% more negative samples. And we didn't get an additive effect. We found that the contingency management produced the big bang for the buck. DA is using contingency management as its main treatment strategy for treatment of individuals with stimulant use disorders, and is getting their reports are very positive on this technique. There are three challenges right now to the use of contingency management. The biggest one is the Medicaid regulations. For people who are in treatment with Medicaid, it restricts their giving them incentives to $75 a year. Now, the studies that I mentioned, people could earn up to a few $100s. In the study I ran, it was up to $500 over time, where they were given incentives to give drug-free samples. So Medicaid restricts the amount of resource we can put into contingency management. And there is a relationship between the amount of reward and the reduction in meth use. So that's a big issue. We're working on it. Wesley Clark and I and a number of others are working with lots of groups to get that restriction lifted, but who knows? If you followed today's news, who knows what's going to happen with decision-making in the government. Where does the funding come from? Right now, we actually have a window of opportunity with the SOR funds that the federal government is giving to states. Those funds can be used for contingency management, but in general, that's been a big issue of like, where do we get the money to do this? And finally, there's been this issue of staff resistance that you shouldn't be paying people to not use drugs. It's not, they should be doing that on their own motivation. And to which I say, look, you work with these folks for 40 years and you find something that works, you're not really like that worried about how it works. You're just interested in it works. And it does work. Now, I'm not going to go through these. CBT has some benefits. There's some modest evidence. Reinforcement has some benefits. Neither of these, though, as robust as what we see with contingency management. I did this study on using exercise. We had people in residential treatment. They were in long-term residential. Half of them got, in addition to their regular treatment, half of them got an exercise program for 8 weeks, 3 times a week. The other group got an education class. We got lots of differences. We found that those who got exercise improved their physical conditioning, reduced their weight gain, their cardiovascular functioning was better. That is, they had increased heart rate variability, which is a good thing. Less anxiety and depression, less craving. We did PET scans on them pre and post. Those who exercised had much more rapid recovery of the dopamine receptor system. And when they were discharged from treatment out into the community, we saw a much lower relapse rate with those who had been involved in exercise. Exercise is not, in my opinion, is not just a good thing that people should exercise because it's a nice thing to do and you feel better. Exercise is a very robust intervention for individuals with meth use disorder that I think should be integrated in treatment. And at some point we could talk about how we're doing that. Last thing I want to mention is this protocol. We've been asked by a bunch of states to help them. I tried avoiding getting involved because I'm trying to retire and set up an animal rescue, but we did decide to help try to put together some components and created a manual that we called Trust Treatment of Individuals Who Use Stimulants. It includes MI, CBT, CRA, well, MI meaning motivational incentives. We use the $75 worth of incentives. Motivational interviewing and physical exercise. We've written a manual, 12-week manual. We send it out to people, no cost. So if anybody's interested in this, we have no idea if it works. All of the elements have evidence of efficacy, but we don't know whether or not this particular combination is better or worse than anything else. It's just trying to give states something that can help implement these evidence-based issues, especially in my mind, the motivational incentives and trying to get exercise built into treatment as a component of treatment. And the focus of it and the priorities of this manual are to try to increase retention and get people into treatment and retain them in treatment so that the strategies we put together are really first and foremost working to retain people over time and then move them into an ongoing program of recovery, with this as sort of the initial primer piece of recovery. So I'm going to stop there so that I can give you more information on this, and certainly we'll be happy. Anybody interested, I'll send you the manual. This is my email, rrawson@mednet.ucla.edu. And if you ask for the manual, the only thing we're going to ask you is that we can call you in 6 months and see, or send you an email and see what you've done with it and whether it seems to be useful to you. That's because we're just interested in what happens with this. So I will stop there and take some questions.
Dr. Rawson, just to clarify, you want them to email you directly. You do not want us to send that manual out to our list of participants?
Well, yeah, because we're wanting to keep track of who we're sending it to so we can do follow-up emails to just get some information from people on whether or not they used it, whether they used it and it wasn't helpful, what pieces of it were useful. I mean, we figure it would probably be maybe 10 questions about their use of the manual. So we're trying to, if you send it to me, we'll send it right out to you electronically and no cost and no, muss or fuss. And so, yeah, I prefer it to do that because then we can keep track and do some follow-up connections.
Okay.
We'll include a note in the evaluation email, Jen, so that people know his email address and can go to him directly.
Okay. Holly Dunn, would you like to unmute yourself? You were asking a couple questions around the internal motivation. Please feel free to ask Dr. Rawson your question.
Sure. I was just making sure I was hearing accurately what he was saying about the most effective treatment. What I heard, which is where I need clarification, is externally motivating treatment interventions like contingency management show the most treatment success. Clinicians who rely on motivational interviewing, CBT, those sorts of things that we tend to assume will increase internal motivation, those aren't shown as effective unless exercise is involved, and then exercise is a key determinant to treatment success. Did I hear that accurately?
Well, I guess it's not that we don't encourage people to use MI and CBT. We do. Those are very useful. The problem is in the research, the dropouts with those treatments have been substantial. I mean, the work that I did with the matrix model, which is CBT and MI and patient education and family involvement. I mean, I think a lot of that was very useful to a lot of people, but you would generally see a third who maybe got a significant dose of treatment, 2/3 who would drop out prematurely. And that's people who agreed to go into the matrix treatment. And a lot won't, because it's, you come in 3 times a week and you have to go to all these groups and stuff. And so to try to get more people into treatment longer, contingency management can add a whole bunch of people who come into treatment, maybe not because they're all that thrilled about reducing their drug use, but because they can get stuff. And what you often see happens is the external motivation will help get you through the first weeks or early months because they're there to get the stuff. And then over time, they start to connect up with their more internal motivation. And so it really is very useful as a way of, I think of it in much the same way I think of buprenorphine treatment. You've got something that draws them in, something that can help them keep coming back, that can help them with reducing their use. But oftentimes then the behavioral treatments, the therapies and MI and the CBT can help them develop longer term recovery. And so it's not either or, it's a matter of the CM providing this really robust way of drawing in a much larger group of people into our treatment system.
Dr. Rawson, in your slide about treatment response predictors, you had mentioned Caucasians have a higher success rate. What considerations are given for minority populations or people of color?
And that's a great question, and it's one that all I can say is in all of the efforts we're doing around the country with this, one of the issues we're making clear is whatever our manual is or whatever these treatments are for like contingency management, you have to adapt them for the needs of the population and the cultural context. I think a great example is a guy named Michael McDonnell from Washington State University, the contingency management for Native American populations, where they got all kinds of input from the Native communities on how contingency management could be done effectively among that population. The same is true for the African American community and populations of men who have sex with men. If you have a women's program, all of this stuff is, you can't just take a manual and plop it down and do the same thing with everybody. You have to adapt it for the population. Now I can say that, and I don't know exactly what that means literally for each of these different groups, but right now we're getting set to do something in California, and we are getting together focus groups of these different groups on how do you think, given these concepts we think work, how do they best get adapted within your community? And I think that's a step that's often overlooked. I know with the Matrix manual, for people were, I was in Vietnam one time and ran into one of the Matrix model trainers who'd been training in the hills of Vietnam with the Matrix manual. And I said, what are you doing? We developed this in Los Angeles in 2000 or in 1985 with, Caucasian college educated people. Are you seriously taking this same manual and doing it with villagers in the hills of Vietnam? I mean, all these talk therapies really have to be adapted for the population and the cultural context. And we're not doing that particularly, but anybody who's going to use these materials needs to think that through carefully.
Jen, any other questions? Okay. Dr. Flaherty, are there any parting comments you'd like to make before we give Dr. Rawson the final word?
I just wanted to comment that I neglected to mention that, but something that's very obvious to you all know, that when you travel the country and the world and you ask somebody, who should you talk to when it comes to understanding stimulant use, abuse, and it would be the name Rick Rawson. But so I really wanted to thank you, Rick, for an excellent presentation clinically and scholarly with the research. I feel like I've learned a great deal, and I'm sure that all of us in the audience have too. So thank you very much.
Good. I enjoyed it. I enjoy doing these talks, and it's very, if I can be of help in the future, let me know.
Dr. Rawson, this is Presha. And I just want to tell you, you should never say that to me, because I will always take you up on it.
Right.
So expect to hear from us again.
Right.
I think even if we spent one time just going over all the clinical interventions. So thank you so very much.
You're welcome. Have a good day.
Thank you, everyone. We'll be sending out the evaluation email shortly. Have a great day.
Thank you all.
Thank you.